I'm Dr. Saxena. I'm a consultant cardiologist at Apollo Hospital, Delhi. Today, we are going to discuss the newer therapies for management of hyperlipidemia. Before we start discussing about the treatment, there are two important aspects. We all know that atherosclerotic disease, whether it's a cardiovascular or cerebral or anywhere in the body, is a result of deposition of cholesterol in the arteries. And the most important factor which determine the disease is the level of LDL cholesterol. Now, this LDL cholesterol is high because of heterozygous disease, or it may be in the homozygous patients. It has been shown that Indians have a higher cardiovascular risk and experience early cardiovascular events. Elevated LDL cholesterol levels are crucial due to the strong and linear association with atherosclerotic cardiovascular disease. You can see that various trials have been summarized here, both for the primary prevention and for the secondary prevention. And when you see the LDL cholesterol level of 50, 100, 150, as and when it keeps going up, the incidence of coronary heart disease keeps increasing. In fact, each 1 millimole per liter, that's roughly 40 milligram per deciliter, decrease in LDL cholesterol is associated with 21% reduction in major cardiac events. So it's very clear from various multi-center studies and trials that LDL cholesterol directly related to causation of atherosclerotic disease, and decreasing the LDL cholesterol level has a significant effect in reduction of cardiac mortality and morbidity. The latest guidelines recommend that you should strike early, strike strong for intensive LDL cholesterol lowering to achieve the targets, especially in the high-risk patient. 2023 European Society of Cardiology guidelines, they recommend the reduction to less than 55 milligram per deciliter in patients who have got a second cardiovascular event within 2 years. An LDL cholesterol goal of less than 40 milligram per deciliter confers additional benefit. These findings have been confirmed by the 2022 American College of Cardiology Expert Committee. Now, Lipid Association of India, in a consensus update, recently have classified these patients into 4 groups. One is a high-risk cardiovascular risk, where the target is LDL of 50, less than 50. Extreme cardiovascular risk category A, when the LDL cholesterol again to less than 50 and optionally to less than 30. Extreme cardiovascular risk category B, less than 30, and extreme cardiovascular risk category C, the desirable level have been brought down to 10 to 15 milligram per deciliter. This may sound a little unusual to you, but consensus is that those patients who have undergone bypass surgery or who had multiple cardiovascular interventions with the angioplasty and stent implantation or multiple infarcts, a LDL cholesterol reduction to 30 milligram per deciliter is strongly recommended. There are a concern about the safety outcome of reducing the LDL cholesterol to very low level, because the cholesterol level, blood cholesterol are important for synthesis of steroids and other hormones. But in various studies, it has been found that there is no significant association between very low LDL cholesterol. A secondary analysis from 4-year trial showed a cardiovascular benefit with the further lowering of LDL cholesterol level and no safety concerns even when the LDL cholesterol is less than 10 milligram per deciliter. Now, it is not always possible to bring down this level of LDL cholesterol to less than 30 with the drug therapy alone, which is existing, especially the statins and ezetimibe, bempedoic acid recently included. So a newer therapy has come, that's inclisiran, which has been introduced almost a year back. inclisiran is a first-in-class sRNA therapy to lower the LDL cholesterol. It mimics the body's process of RNA interference. It directly acts in the liver and directly suppresses the RNA. It prevents the production of target protein with a greater hepatic uptake of circulating LDL cholesterol, which causes reduction of LDL cholesterol in the blood streams. Now, inclisiran is indicated in adults with primary hyperlipidemia, that's a heterozygous familial hyperlipidemia and non-familial hyperlipidemia, or mixed dyslipidemia. Most of the time, we start these patients on a statin. We go to the maximum dose of a statin, that's a rosuvastatin 40 milligram or atorvastatin 80 milligram. If a patient tolerates this and still the cholesterol level is not controlled, better to add ezetimibe. And again, check the blood levels. You can add bempedoic acid. Now, there is a group of patients who is on all these drugs and his cholesterol is not under control. Second group of patient who is not able to tolerate the lipid lowering therapies, especially the statins. So you can use inclisiran either as a single isolated drug in those patients where statin therapy is not possible, or you can use it as an add-on to statin therapy when the cholesterol levels are not controlled in spite of optimal therapy. Now, inclisiran is useful in high-risk individuals with atherosclerosis whose high LDL cholesterol levels remains inadequately controlled with a standard lipid lowering therapy such as statins, ezetimibe, or bempedoic acid. It is also useful in the treatment of heterozygous familial hyperlipidemia. The recommended dose is 284 milligram administered as a single subcutaneous injection. It's a 1.5 ml solution which anybody can use like you use insulin injection. The index dose is the first initial dose. The second dose is to be repeated after 3 months, and then every 6 monthly the injection is to be used. If a patient who is already on inclisiran, if he miss a dose by less than 3 months, it can be continued as it was being done previously. But if a dose is missed by more than 3 months, a new dosing schedule is to be restarted. Now, second thing is those patients who have on the maximum tolerable statin therapy and who are on monoclonal antibody PCSK9 inhibitors. In this group of patients, inclisiran can be administered immediately after the last dose of PCSK9 inhibitor. And to maintain the LDL cholesterol lowering, it is recommended that inclisiran is administered within 2 weeks after the last dose of monoclonal antibody PCSK9 inhibitors. So these are CSI guidelines of management of dyslipidemia. You check the lipid profile. You start the patient on 40 milligram of rosuvastatin plus ezetimibe. See the levels. If the patient is not responding, then or the levels are not achieved, just less than 55. These are the patients who are for inclisiran. Second group is those patients who are not able to tolerate the maximum dose of rosuvastatin or other statins. Now, as far as our country is concerned, the Cardiology Society of India guideline recommend that in patients with ACS, if an LDL cholesterol target of less than 55 milligram is not achieved with high-intensity statin, ezetimibe or bempedoic acid, then another non-statin drug like PCSK9 inhibitor or inclisiran can be administered. And these have been reconfirmed by Lipid Association of India. So these are various indications for secondary prevention and primary prevention. We have already discussed about the levels which you are going to achieve. Now, the two type of injection therapies are available, as we have already discussed. One is the PCSK9 inhibitors, which are to be given every fortnight, or inclisiran, which can be given once in 6 months. So it has the advantage of less number of injections and a consistent lowering of LDL cholesterol. Pivotal phase 3 trial, there are three trials, Orion 9, Orion 10, and Orion 11. They have been done in hereditary familial hyperlipidemia, in patients with atherosclerotic cardiovascular disease, and in a patients with a atherosclerotic cardiovascular disease or the risk equivalent. Various groups have been involved, and the doses have been 284 milligram or a matching placebo, and it has been followed up for a period of 18 months. The pooled analysis shows that inclisiran therapy will cause a sustained reduction in LDL cholesterol by almost 50% over the baseline. Similar findings have been found in those patients, in the those who are in Asian patients, and where this has been used as a single drug or as an add-on drug uh, with the statins and ezetimibe. So again, the data has been done and it has been shown that there is a significant, almost 47 to 50% reduction in the LDL cholesterol and 33.6% reduction in the total cholesterol level. Now, as far as the safety studies are concerned, inclisiran was generally well tolerated with a safety profile similar to a placebo, apart from the injection site incidents, which may happen in some patients. They are non-serious. They can cause local itching, local edema, and allergic reactions. It's a well-tolerated, proven safety. The studies have been done up to 7 years of exposure. Now, Orion 8, which is an open label extension trial of Orion 3, 9, 10, 11 of 3,000 patients. The long-term efficacy and safety of twice yearly inclisiran has been proven. Now, inclisiran acts in the cytoplasm of hepatocyte and not in the nucleus, so there is no risk of carcinogenicity and immunogenicity. This is a result from the Orion, the largest long-term safety and efficacy follow-up trial, and no significant side effects have been reported for use up to 7 years. There are Orion 4 and Victorian 2P are ongoing trials with complete data anticipated by 2027, and a Mendelian randomized study with 20 million person years of follow-up proven dose-dependent log linear association between the absolute magnitude of exposure to the LDL cholesterol and risk of atherosclerotic cardiovascular disease. So it's a proven drug which is finding its use. More and more patients have been offered this sort of therapy. It has main advantage that it has no side effect like statins, no muscle weakness, no hepatic injury. It's very well tolerated in those patients and causes a consistent reduction in LDL cholesterol by 55 to 60%, even in the short term and long term use. And it's to be given twice a year. Thank you very much.